Okay, well, we're still working on hypertension. I believe we're on about page 686, 687 in your book. So Monday, we just finished talking about complications from hypertension. So this is again why we consider hypertension the silent killer, because usually patients don't have problems from high blood pressure until they start getting older, which we talked about on Monday. This picture here is showing you hypertrophy of the left ventricle, and again talking about how this can be a complication of hypertension. I don't think you guys have this picture. It's in your book though. All right, so some diagnostic studies for hypertension. Again, there's no one test that we can do for hypertension, but a lot of these studies, why are we doing these diagnostics for hypertension? Right, this is focusing on all those problems that can happen from hypertension that target organ disease from hypertension. So we want to rule out causes also of secondary hypertension, evaluate organ disease, look at the patient's cardiac risk from having hypertension, and we always want to establish a baseline of some of their labs before we start them on antihypertensive meds, because some of those meds, we'll talk about this in future diagnostic studies. So your analysis, BUN and creatinine, what are those going to look at? Kidney function, right? And when we're talking about kidneys, guys, if you could pick one test to hone in on the kidneys, what would it be? Creatinine, very good. Electrolytes, especially what electrolyte are we looking at? Potassium, right? Especially the potassium is important to detect different problems that can happen from taking antihypertensive meds. A lipid profile, because that's going to tell us about risk for CVD, atherosclerosis. Uric acid levels, why are we doing those? For gout? Yeah. But why are we doing them for our hypertensive patient?
But you need a baseline.
Because?
Due to the diuretic meds?
Yes, some of the diuretic meds can cause uric acid levels to rise. So just like she said, it's a baseline. An EKG or ECG is going to give us more information about cardiac status, left ventricular hypertrophy, any ischemia if the patient had an MI. Again, blood pressure monitoring. An ambulatory blood pressure monitoring is non-invasive. It measures the blood pressure at preset intervals over a 24-hour period. This is useful for those patients who have elevated blood pressure readings in the clinical setting, but they have normal blood pressure readings when they do them at home. So it gives us a more accurate picture of what their blood pressure is doing. And again, we refer to that as the white coat hypertension. Also, we can use want to monitor patients' blood pressures at home, because blood pressure at night during sleep usually drops by 10% or more from daytime when the patient's awake. Some patients with hypertension do not show a normal nocturnal dip in their BP. So again, the ambulatory blood pressure monitoring can help with that as well. So our goal with our hypertensive patients obviously is to control their blood pressure, reduce the risk of cardiovascular disease, and reduce the risk of damaging their organs. So again, lifestyle modifications, we've talked about a lot of this. We talked about this in seminar, the case study directed right to this. So weight reduction, we're going to kind of slide through these slides because this is not new information to you guys. Obviously, people that are overweight have an increased risk of hypertension, increased risk of cardiovascular disease. Weight reduction with restricting calories, physical activity is our recommendation. The DASH diet, so fruits, veggies, fat-free, low-fat, milk, whole grains, fish, poultry, beans, should be the diet that we're recommending for our patients. So how should we gear our education to these people? Do we just say, hey, you need to eat this and see you next month? What do you guys think? Or what if we sent the patient out the door and said, you need to lose 50 pounds by the time you come back? You need to start running on the treadmill.
Just get one of them today.
Okay. What can can you do as a nurse though? Teach them, to educate them.
Oh, you keep a food diary.
Okay, a food diary, how to read labels.
Check the blood pressure.
Okay, yep. But how can I help these patients be successful in this stuff here? There you go. Find out the foods they like and then help teach them how to modify those foods, okay? Baby steps, guys. We are just going to set our patients up for failure if we send them out the door and say, you need to lose 50 pounds, you need to do this, you need to stop this, don't eat that, don't do this. I mean, think about yourself. How would you feel if someone like gave you a whole list of everything that you need to do and that what you can't do? You might not be as successful, but if we can take these things and assess their lifestyle, assess their eating habits, and help teach them how to change some of those habits into a healthier version. So now that I said that, what are some examples you could teach your patient or what you could tell them?
Not to use table salt.
Okay, not to use table salt, but we need to give them a substitution.
There goes Mrs. Dash.
Okay, there's Mrs. Dash, but we got to be careful sometimes with Mrs. Dash because what's the bad side of Mrs. Dash? Yeah, sometimes it has too much potassium. So depending on your patient, let's say you have a patient that has kidney failure and hypertension, they can't have all that extra potassium because the kidneys are what get rid of potassium for us. But that's a good, if it applies to the patient, we can teach them about Mrs. Dash. What else? What? Lemon, right. Sorry, guys. Teach them other ways that they can spice their food with other things besides just salt all the time. Any other thoughts up here for educating your patients?
Sometimes fresh herbs do a lot.
Yes, fresh herbs.
That was realistic goals, like 2,000 or something.
Right. Give them realistic goals because that is great advice because if someone can lose 2 pounds in a week, that might motivate them like, oh, I can do this. But if we send them out with an unrealistic goal for weight loss or an unrealistic goal for exercise, so what would be a good exercise we could encourage our patients to do? Walking, right. If the patient's mobile, everyone can walk, okay, if they're mobile to do it. Something else we get for weight loss exercise is like swimming, for example. It's low impact, easy on the joints, okay? So the point here is you need to tailor this to your patient, to your patient's lifestyle, okay? And you're only gonna know that, and you gotta sit down, you gotta talk to people, guys, all right? We gotta talk to our patients. So we talked about physical activity. You guys can read the slide. Smoking. We're always talking about not smoking. Reducing salt in the diet. Healthy adults should reduce their sodium to less than 2,300 milligrams a day. The American diet is terrible for salt. In general, we salt our food a lot at the table. We salt with cooking. A lot of people, our lifestyles are eating out, and there's a lot of salt in food when you eat out too. Moderate alcohol consumption, and we talked about physical exercise. So what should we be telling people for exercise? How much should they be exercising?
Tell them 150 minutes a week.
Okay, so 150 minutes a week, you can tell them about 30 minutes for most days, about 5 days a week, which equates to 150 minutes a week. We talked about walking. All right, let's get to the drugs. So it's no big secret in here, guys. You're taking a test on Monday on hypertension. So you're probably going to have test questions on drugs, right? And you guys have been giving these drugs for 2 years, at least, in clinical, all right? You need to know your antihypertensive drugs, all right? This is not new information to you guys. So with our medications, obviously the goal is to treat the blood pressure to less than 140/90. What patients do we want their blood pressure even lower, like 130/80? Diabetics? We only care about diabetics?
Kidney failure.
Yes, thank you. Our kidney patients, African American patients, remember they tend to have a slightly higher blood pressure, so we want to control them a little lower. Our smokers, they need to have a lower target for their blood pressure. So the meds that we use to treat hypertension, they're going to decrease the volume of circulating blood, and they're going to reduce systemic vascular resistance, which is what hypertension is. So in your book on page 691, starts the table for drug therapy. With any of these antihypertensive meds, what do we always teach in our patients when they're taking these meds? Change position slowly, because these patients, it's common that when patients start blood pressure meds, they can become orthostatic, they can fall easily, they can become dizzy. All right, so the drugs, diuretics. Again, the exact action of diuretics on blood pressure is not fully known or fully understood, but they do promote water and sodium to be excreted. A lot of times with diuretics, for example, loop diuretic, when we're flushing out water and sodium, what else is going out with it? Potassium, right? So again, this is back to why we want to assess our patients' electrolyte levels before starting therapy, while they're on therapy. Diuretics reduce plasma volume, so all that will reduce vascular response. Adrenergic blockers, these decrease the sympathetic nervous system, that increases blood pressure, and they also inhibit norepi release, because norepi makes us excited, right? Brings up our heart rate, brings up our blood pressure. Vasodilators, what are they going to do? What?
Decrease blood pressure.
Right. How are they going to decrease the blood pressure, though?
Open up so there's less resistance.
Exactly. They're going to relax that vascular muscle to help bring blood pressure down. Calcium channel blockers, what are they going to do?
Block the calcium from having a hardening in the heart.
Yes. We had been clinical before. So think about it, guys. Calcium into a cell likes to excite it. Okay? So think of calcium likes to have a party in the heart, and we don't want that, right? A lot of times we give calcium channel blockers. Calcium channel blockers are not always the first go-to for hypertension. We use a lot of times calcium channel blockers for, bonus question, what cardiac condition? Okay, you're very warm. Atrial fibrillation, tachyarrhythms, right, very good, thank you. So remember guys, calcium, when it gets in the cell, it gets it all excited, okay? Just like potassium, when we have too much potassium, it causes too much excitement. So calcium likes to have a party in the heart. So think about it in simple terms. Calcium channel blocker, block means I'm stopping calcium from coming in, okay? But with hypertension, calcium channel blockers increase sodium excretions. That also helps with that diuretic effect, causes vasodilation, and prevents movement of calcium into cells. ACEs, what do ACE inhibitors do? Right, because angiotensin is what? Right, it's a potent vasoconstrictor. So we stop angiotensin 1 from converting to angiotensin 2. And then ARBs, what do? The B stands for blocker, the A stands for, right, so they're blocking angiotensin from sticking into those vessels, okay? Patients should not be on ACEs and ARBs together, it's one or the other, okay? Usually they start them on ACEs most of the time, and then if they have a problem from their ACE, then they'll switch them over to an ARB. And then in your book on page 694, talks about some of the combination drugs. A lot of times we'll see these ACE inhibitors, for example, combined with a diuretic, okay? 694. So again, once we start patients on their antihypertensive drugs, they need to come back for follow-up to make sure their blood pressure is controlled. Side effects from antihypertensive drugs are common. They may be so severe or undesirable that patients don't comply with the therapy. For example, diuretics. Especially our young people. If we have a young person that comes in and they're on the borderline of hypertension, a lot of times we'll start them on a diuretic first. What would be an example of a diuretic you start them on? No, we don't go that aggressive. She said Lasix.
Hydrochloroquine?
Right, hydrochlorothiazide. Hydrochlorothiazide, think of it like a baby Lasix, okay? It still has a lot of the properties that Lasix does. It can waste your potassium. It is a diuretic, but it's not as strong as furosemide, okay? But again, sometimes patients don't like the side effects of the blood pressure meds. For example, if they're on a diuretic, they're going to the bathroom all the time, okay? Some people feel better when their blood pressure is a little higher because they've been used to that for so long. And now that we got their blood pressure down to a normal level, they don't feel as well. For example, have you ever taken care of a diabetic who likes it, feels good when their blood sugar is 180, and then when their blood sugar is 80, they feel like crap, right? But 80 is normal, okay? So again, we talked about a common side effect of our antihypertensives is orthostatic hypotension. So teaching them to change position slowly. I think this is on the previous slide. Yeah. Sexual dysfunction, sexual problems can also occur with some of the antihypertensive drugs and can be a major reason why patients don't take them. They can cause reduced libido, erectile dysfunction. And again, when we talk about sexual dysfunction for some patients, this can be an embarrassing topic to talk about anybody with, even their doctor. So maybe instead of talking to their doctor about erectile dysfunction, for example, they just stop taking their antihypertensive meds, okay? We talked about the diuretics. I think that's good. All right. So again, this information's in your book for health assessment. We're not going to go in depth on it. It's on the slide here. But what we should be doing, past medical history, always with our hypertensive med or our hypertensive patients, going back and looking at their medications that they're taking. What are they taking? Are they taking it? Are they taking it like they should? Okay. I have a lot of patients that I'll ask them, oh yeah, I'm on lisinopril. And then you always follow up with, well, when's the last time you took it? And then you find out, like 2 months ago. Then you ask, well, why haven't you been taking it? And they'll tell you, well, it makes me dizzy, or I can't afford it, or whatever the reason might be. We want to assess patients' nutritional status. And we talked about that, their salt intake, fat intake. Their elimination, we want to assess that because why? Why do we put elimination up here? But why do we need to be assessing patients' elimination patterns with antihypertension?
Because hypertension affects the kidneys.
Yes, it affects the kidneys and also maybe some of the treatments, the diuretics that we're giving them. So we want to assess the patients. They should be taking their diuretics first thing in the morning, not taking them at night because they're going to be up all night going to the bathroom. How are they tolerating activity? How are they tolerating exercise? Are they getting fatigued, short of breath on exertion? Are they having palpitations, chest pain? And again, we talked about these up here, sexual reproductive assessment. How are they coping with the diagnosis of hypertension? I'll tell you guys, I see a lot of people that are young people that are having hypertension. When I went back for my BSN, we had to do a internship rotation in public health nursing. So I chose school nursing. Not my cup of tea. But if anyone out there loves school nursing, go for it. Not for me though. And we had, and I did the Princeton school. So if anyone's from Princeton, and that school nurse, she did everything. She did from kindergarten all the way through high school. And in Princeton, they had like 6 different schools, and we were going to what's that little bitty town that's got the 4th and 5th grade? Who's from Princeton? Somebody? Anybody? Nobody?
School?
Yeah, is that the name of the town? I think so. It's like 9 miles outside of Princeton, and that's where the 4th and 5th grade was. We'd have to travel out there. There was a kid in kindergarten that had some other cardiac issues, but we were giving him like beta blockers and some other cardiac drugs as the nurse, okay? We had kids in the high school that were coming in to have their blood pressure checked by the school nurse because they had hypertension. And their doctor wanted them to have it checked while they were at school, and they were taking antihypertensive meds. So hypertension, guys, is not a disease of old people. This affects everyone across the lifespan. So we always want to make sure that we're assessing how patients are coping with the diagnosis. And I'll tell you, based on experience, this is not like evidence-based, but based on experience, The patients I see that don't comply with their antihypertensive regimen is the young people. The old people, they'll take their blood pressure meds because they're used to taking 800 pills a day, okay? The young people don't comply with their blood pressure meds as well. All right, and then objective data. This is some focus assessment we should be doing on our antihypertensive patients here. All right, we talked about this Monday, how to properly take a patient's blood pressure. This slide up here is talking about how to take a patient's blood pressure when you're checking for orthostatic hypotension. You have to do lying, sitting, and standing. You have to get a blood pressure and pulse, and how long do you wait in between time? Right, 1 to 2 minutes, exactly. All right, some nursing diagnoses that we could come up with for our hypertensive patients, and then our planning. Again, we want our patients to maintain goal blood pressure. We want them to understand what they're taking, why they're taking it. So health promotion, primary prevention of hypertension. This is such a big public health concern because hypertension is a very expensive disease, okay? And why is that? Right, it doesn't necessarily just mean hypertension is an expensive disease. All the organ problems that come from undiagnosed, undertreated, or not treated hypertension. So from a public health standpoint, this is a big one. So primary prevention of hypertension is a very cost-effective approach. Obviously, we want to educate the public, educate our patients before they become hypertensive. And I'll tell you what, anyone have kids like in grade school, high school age? Are they doing this in the schools?
They're not telling me what they are.
Okay, right. Kids that age, they're not going to tell you how their day was, right? But this stuff needs to start at that age, okay? The diet, the lifestyle changes, the exercise. I'm sure in their health class they're teaching them this stuff. But starting to teach people about health promotion at 60, I mean, yeah, that's great, but this needs to start way before then, okay? So us as nurses, this is the population, those young people that we really need to start this education with, okay? All right, non-compliance. So again, we've talked about this. What are some reasons that patients are having problems with their blood pressure? Why is their blood pressure not controlled? We need to hone in on these problems here. Did we give them an adequate teaching? Okay, remember guys, I see this with especially new nurses. They just sometimes don't know what to say to their patient, and they're like, here's your ACE inhibitor, take this every day, we'll see you in a month. All right, you gotta talk to your patients, you gotta educate them. Remember guys, this stuff makes sense to us because we're nurses, okay? We're in the healthcare field. But to the general public, they don't understand this stuff all the time. And like I told you guys, you need to be in the habit of talking to all your patients. You're not dumbing them down. You're not trying to be disrespectful to them, but you want to talk to everybody as though they're on a 5th grade learning level, okay? Making sure that they understand what they're taking, why they're taking. I see all the time patients are on medications, and a lot of cardiac meds are given for many reasons, whether it be atrial fib or hypertension. And I'll ask the patients, well, why are you taking this drug? I don't know. And that's such a disservice to our patients when they don't know what they're taking, why they're taking it. Are they having unwanted side effects? We're only going to know that if we ask our patient, okay? And then you guys can read the other reasons up there to for non-compliance. So things we can do to help with compliance, and we've talked about a lot of these. Patient and caregiver teaching, again, this is kind of a repeat. We've already talked about this. And then our evaluation. So again, we want our patients to have a normal blood pressure, understand, accept the plan, and experience minimal to no side effects. Now, we didn't go over in depth all the details of all those antihypertensive meds. You guys have had this multiple times before. You guys have all been through pharmacology. You have given all those blood pressure meds in clinical. So you guys need to brush up on your antihypertensives, okay? You don't have the time in this 8-week course to reteach you antihypertensive meds, to reteach you pharm, okay? So make sure that you are understanding your meds. Okay, question, please just give everyone time to think about this. A patient's blood pressure has not responded consistently to prescribed drugs for hypertension. The first cause of this lack of responsiveness the nurse should explore is what's the track? Go for it, Amanda. Yes, 3 is the answer. Patients not adhering to drugs or to their therapy. While all of these can be possibilities, okay, side effects of antihypertensive drugs are common, and these are usually the first reason why patients are not taking their medication. You know, very good, guys. Gerontology considerations, we talked about these on Monday. A lot of this is just kind of a recap on gerontology considerations. You guys have the slides on these, and this is in your book. So you guys take care of patients all the time that have hypertension, that are on blood pressure meds. You guys, we did hypertension as first-year students. But maybe something that is new to you is talking about hypertension when it's an emergency, okay? So hypertensive crisis, this is the term that we use to either indicate hypertensive urgency or emergency. And again, this is determined by the degree of target organ disease and how quickly the blood pressure must be lowered. An hypertensive emergency is going to occur over hours to days. This is when patients' blood pressures are severely elevated, like 220 over 140. They could have woke up that morning, their blood pressure was completely normal, and by the evening, this is now their blood pressure. This is an emergency, okay? We got to get these patients' blood pressures down. Hypertensive urgency, again, it's urgent, not emergent, because this happens over days to weeks. And this is when the patient's blood pressure is in the 180 over 110 range. The rate of the rise of the blood pressure is more important than the actual number itself. So if you have a patient in the hospital and you check their morning blood pressure at 8 o'clock and it was normal, and then you check their blood pressure at 10 a.m. and it's 220 over 40, that's an emergency because that blood pressure raised so high in 2 hours. All right, that's a bigger deal than the patient's blood pressure going from 120 over 80 to 220 over 40 over 2 week span. Does that make sense? Okay. What's the correlation? Who do we see having hypertensive crisis? Whose patient's blood pressure is raised like that? What's a potent vasoconstrictor? It's illegal. Cocaine use, right? So sometimes we see our patients that abuse cocaine. This is their problem right here. They go into hypertensive crisis. In your book on page 698, lists some other causes. There's a little table there that talks about reasons why patients can have hypertensive crisis. So clinical manifestations, hypertensive emergency, these patients will have hypertensive encephalopathy, they have a sudden rise in their BP, a severe headache, nausea, vomiting, seizures, confusion, coma. This can also be seen in patients that all of a sudden stop taking their blood pressure med for whatever reason. These patients will have a rebound hypertension. So these patients right here, what are they at major risk for having? Stroke. right? Exactly. These patients, because they get cerebral edema and a disruption of their cerebral function on retinal examination, they'll have hemorrhages, papilledema. Again, not typically an exam that a nurse will do, but if you ever put the light up to their eye, you can see it. It's really bad. Renal insufficiency, these patients might be at risk for going into complete renal failure when their blood pressure gets this high. This is usually a rapid rise in the blood pressure. This is an emergency. They're going to have rapid cardiac decompensation. They're going to have unstable angina. They can possibly have a myocardial infarction, which is the medical term for a heart attack, pulmonary edema, chest pain, dyspnea. Aortic dissection, which is a big deal, can develop and will cause sudden excruciating chest and back pain. How else would we know if patients having a problem with their aorta? We're going to talk about it today, but hopefully you prepped a little bit. Peripheral pulses, peripheral especially where? Right, the pedals, exactly. Absent pulses or reduced pulses in the extremities could, with the excruciating chest and back pain, could be pointing to an aortic problem. So, how are we going to treat these patients in hypertensive crisis? They have to go in the hospital, guys. These aren't patients that can just double them up on their blood pressure meds and send them home, okay? They require hospitalization. They need IV antihypertensive drugs. And usually they're going to go in the ICU for monitoring. Again, when we have someone that's in hypertensive crisis, what's the best method for taking their blood pressure? What? Yes, manually. Yes, we can use an arterial line. But are we really looking at those blood pressure readings over and over and over? What number are we looking at? The MAP, right? Their mean arterial pressure, okay, is going to be our guide for our patients in hypertensive crisis emergency. Now, with these patients, you can't just drop their pressure like this back to normal, okay? You got to kind of bring it down a little bit slower, okay? Because those patients, you can stroke them out too if you drop their pressure too much. Did you guys learn when you guys did neuro that your stroke patients, sometimes we want their blood pressure a little slightly elevated? We don't want to drop them completely down to normal if someone's having an acute stroke. Do you guys remember talking about that? Right. Same thing here. The initial goal is to decrease the MAP by no more than 20 to 25%. If we lower the blood pressure too fast, if we lower the blood pressure too much, what are we going to do to the patient? Right, so we're decreasing perfusion to the brain. We're decreasing perfusion to the kidneys, right, and we're decreasing perfusion to the heart, okay, which is why the patients can go into kidney failure, why patients can have a stroke, why patients can have a heart attack. Does that make sense now when you talk about it that way, okay? When we give antihypertensive meds IV route, they have a rapid, we're talking within seconds to minutes, result for the patient's blood pressure. When you guys give these meds IV push, you just can't go in there and push them in the patient, all right? You're giving these meds slowly over time. If you don't know how to give these meds, what do? Yes, thank you, look it up. Okay, you have to know how to properly administer these medications IV because you can cause a lot of damage to your patient. When you're giving patients IV blood pressure meds, how often should you be monitoring their blood pressure? Right, minutes, guys. These aren't your patients on the floor that you check their blood pressure and an hour later you'll come back. When you come back in an hour, your patient could be laying there stroked out, okay? These are patients that when you're giving these IV antihypertensive meds, you're staying at the bedside with these patients. You're assessing their blood pressure every 2 to 3 minutes, okay? Because they can be very sensitive to their blood pressure dropping. And a lot of those antihypertensive meds can affect the heart rate too, okay? If we're given these antihypertensive meds, we should always have these patients on a cardiac monitor because these meds can also, like I said, affect not only bradycardia, but they can cause cardiac dysrhythmias as well. And a big side effect of having hypertensive crisis could be having an MI. And if a patient starts having dysrhythmias, it could alert us that the patient could possibly be having an MI. We want to assess renal perfusion, so how do we do that? Right, we want to make sure the patient is putting out urine, and we want to accurately be measuring their urine output. A lot of times when we have patients with hypertensive crisis and we're giving them IV, and these patients could be getting IV push meds for their hypertension and or be put on a drip as well. These patients, usually we're not getting them up, guys. These aren't the people that we're worried about in the next 12 hours. Get up and do your range of motion and, you know, do your walking and whatever. We usually keep these people in bed because why?
Because the antihypertensive meds can lower the blood pressure and cause safety or fainting.
Right, these patients are even at greater risk for orthostatic hypotension, okay? So we want to make sure with these patients we're doing frequent neuro checks, assessing their LOC, assessing their pupils, assessing their movement in their extremities. And then once we get the patient stable, we always want to investigate what caused this hypertensive crisis. Did they stop taking their medication? Do they have a problem with cocaine, and now we have to give them some help and rehab with that? So we always want to make sure we try to find out what caused this problem. And maybe nothing caused it, okay? But we always want to make sure we're assessing and subjectively talking to our patients. Okie doke, there's hypertension. Coronary artery disease, this is starting in your book in chapter 33, page 702. Now, this is an introduction to coronary artery disease. We're just going to start talking about the basics. We're not going to get into MIs until next week, okay? This is just covered on about 10 pages in your book, what you guys need to know for this test coming up. So page 702 to 712 is all we're covering for this unit out of this chapter. Next week, we'll get into more of this chapter. So, coronary artery disease is the most common type of cardiovascular disease, and it accounts for the majority of death. Patients can be asymptomatic. Patients can range from unstable angina all the way to having an MI. All right, so atherosclerosis. Coronary artery disease is a type of blood vessel disorder that is included in the general atherosclerosis. This is more what we're going to talk about for this unit, is the atherosclerosis, diet, lifestyle changes for cholesterol, and then next week we'll get into more next unit for atherosclerosis can occur in any artery of the body, but it usually likes to hang out where? In the heart, the coronary arteries, right? So the pathophys is in your guys' book. Atherosclerosis is a major cause of coronary artery disease. What essentially it is fat in the artery, okay? Deposits of lipid in the artery. Also, endothelial injury and inflammation can play a central role in the development of atherosclerosis. So there's different stages of atherosclerosis. Do you guys have to memorize these? No, you don't, but they're here. The stages, they develop a fatty streak, then they develop a fibrous plaque, then the patient has the final stage is the development of the atherosclerotic lesion, and this is the most dangerous stage, the complicated lesion that can happen. And you see over time from looking at this picture how that lesion can build and build and build, and where it can block off the vessel, okay? And when we have a complete blockage of the vessel, these are patients, if it's in the heart, are having an MI. Some more pathophys, the CRP. This is increased in a lot of people with coronary artery disease, but it also goes up with inflammation in general. So this might be a diagnostic test that you see done with these coronary artery disease patients. Collateral circulation. So our patients that have MIs, that have good outcomes, a lot of times these patients have developed collateral circulation. So what that means is this lesion, this atherosclerotic lesion, is building slowly over years, okay? So what can happen, for example, in the heart is patients can develop collateral circulation on their own, nothing that we did interventionally, around that lesion, okay, so that they don't have complete blockage. Those are, you're not going to see, these patients aren't going to be the ones that drop like dead over immediately from an MI, because they develop collateral circulation. And then here's some different pictures here. Obviously, this is what the picture A is what we want all of our arteries to look like. Picture B is showing that collateral circulation. You see how there in the middle, how that lesion is really starting to close off that artery there. And then you see around how those smaller vessels have connected to make circulation around that lesion. So that in picture C, when that plaque eventually completely clots off, the patient still has circulation, all right? Now these patients can still have chest pain. They can still have angina. But these patients are a lot less likely to be your ones that drop over dead immediately from a heart attack, all right? This takes years, guys. It doesn't develop overnight, okay?
Is it a rare?
For this to happen?
Yeah, it's pretty common.
It's common. Okay, so you guys know this. Risk factors for coronary artery disease. We have modifiable, we have non-modifiable. So we need to really hone in on those modifiable risk factors to teach our patients. We talked about the elevated serum lipids. An elevated serum lipid is one of the four most firmly established risk factors for coronary artery disease. So we look at the total cholesterol, triglycerides, LDLs, and HDLs. We don't just look at the total cholesterol and say, oh, my total cholesterol is 150, I'm good, okay? Because what if your LDLs are really bad and your HDLs are really too low, okay? HDLs carry lipids away from arteries. That's why we want more HDLs. And how do you raise your HDLs? Exercise, very good. And then LDLs are our bad cholesterol, okay? So our LDLs, we want them lower. And we talked about serum lipids when we talked about hypertension. Hypertension, we're not going to go over this slide in depth, but again, this can be a risk factor for coronary artery disease. Smoking, you guys all know smoking's bad. Physical inactivity, we talked about this. Physically inactive patients are at risk for coronary artery disease. Obesity is a risk for coronary artery disease. Diabetes, the incidence of coronary artery disease is 2 to 4 times higher in your diabetic patients. And then metabolic syndrome. What is metabolic syndrome?
The cluster of risk factors.
Right, right, exactly. What risk factors are those? Diabetes, hypertension, high cholesterol, so insulin resistance, and a large waist circumference. That's all clumped under metabolic syndrome. Increased waist, hypertension, abnormal serum lipids, elevated fasting blood glucose. These patients are at risk for coronary artery disease. Okay, so practice question. There's 2 of them. 2 risk factors, and again, a lot of this stuff is just a recap of what we just did with hypertension. 2 risk factors for coronary artery disease that increase the workload of the heart and increase myocardial oxygen demand are You might want to take a try.
B.
B, yes, very good, thank you. Elevated BP and cigarette smoking, because cigarette smoking causes what problem? Vasoconstriction. So think about this patient right here. Not only do they have the plaque buildup from possibly genetics, poor diet, but now if they smoke on top of it, they're taking that already damaged vessel that already has plaque building up in the middle, and now they're just closing that vessel off even tighter. That's what cigarette smoking does, okay? All right, which patient is at most risk for developing coronary artery disease? It's kind of the same question. We already kind of did this, right? Yeah. Sorry, those two questions are too much alike. The hypertensive cigarette smoking patient. All right, so our collaborative care nursing management for our coronary artery disease patients. We want to identify those patients that are at high risk. Again, with coronary artery disease, this is something that develops over time, kind of like hypertension. We're not just going to see someone walk in the door and be like, oh, they got coronary artery disease. You can look at someone and be judgmental and say, they look like they're at risk for coronary artery disease, maybe based on their weight or their physical mobility coming through the door. But we want to make sure that we're identifying those patients that are at risk for coronary artery disease early, okay? We want to assess these patients for any presence of cardiovascular symptoms. We want to assess their eating habits, their diet, level of exercise. Don't forget their psychosocial history, tobacco use, alcohol ingestion, recent stressful events, possibly like loss of a spouse. Any negative psychologic states? Are they in a state of anxiety right now for something personal, psychosocial in their life? Are they experiencing depression right now? And we want to make sure that we are recommending any preventative measures for everyone that's at risk for coronary artery disease. Age is always going to put you at risk for coronary artery disease. Remember, when we get older, everything kind of just starts to go downhill. Coronary artery disease is more prevalent in the elderly. Gender, ethnicity, genetic inheritance, these are things that cannot be modified. And don't go there. Yes, you can change your gender, but if God made you a woman, you are a woman, even if you decide to make yourself a man, okay? As far as, we're talking about medical things here, guys, okay? So let's not get into all that psychosocial babble-wabble about having sex change, okay? Everybody good there? All right, so you cannot modify your age. You cannot modify your gender, your ethnicity. So the things that we need to hone in on these patients are the modifiable risk factors, right? Diet, exercise, smoking, controlling their lipids, low salt, low fat diets, controlling their hypertension. And again, we talked about this with hypertension, that we want to make sure that we're setting realistic goals for these patients with those lifestyle changes. We talked about our physical fitness that, like Denise said, at least 150 minutes a week. We want, our goal is at least 30 minutes for 5 days a week. That equates to 150 minutes a week, okay? For our physical exercise. We also want to make sure that we're encouraging patients to add weight training to their exercise regimen, so not just the walking. Examples of moderate physical activity, again, the walking, the hiking, the biking, the swimming, we talked about these. And then nutritional therapy, which is our next slide. Low saturated fats, low cholesterol, decreasing the red meat, the egg yolks, the whole milk. So again, we're not telling these patients that you can't have this stuff, but what can we tell them?
Instead of whole milk, drink like skim milk.
Right, changing these things. So if they really love whole milk, trying to switch them over to skim milk. My husband, he is like, only will drink whole milk. He was raised that way. Like trying to get into even like go to 10% is like me beating my head against the wall. So I kind of just have given up. And now that we have a baby, babies have to have whole milk. So now it's just like, oh, see, we gotta have it as healthy as for the baby. Well, the baby needs the fat. We're in our 30s, we don't need the fat. So try to take these things and modify them to what the patient needs. So instead of red meat, maybe modifying them to some leaner meats, okay? And we're not telling them that you can't ever have red meat again the rest of your life, okay? But like someone said over here, in moderation. So maybe not eating red meat every day, okay? But again, the American diet, this is what we eat in the United States, okay? And I always pick on my husband. I mean, he's someone that, and he doesn't get it, but he would love to have meat and potatoes every night and drink his whole milk, okay? Because that's just how we were all raised. And again, so showing you the different types of fat, saturated versus monosaturated, going on down to polyunsaturated. So all the things I like are on the, bad side, okay? I think bacon's in there, okay? And then you move on over to the arrow, trying to get better foods. So this is a depressing slide for me because when we go to the good foods, I don't like any of that stuff. I don't want that fish. I don't want that avocado. Give me the bacon. All right? But this is our goal. This is what we should be trying to help substitute patients out for. So patients that like these foods here on the sparingly side, we want to try to give them food ideas to move them on down to the healthier sides, the polyunsaturated. Okay, so these are ways we can teach them to substitute them out. Do you guys have a question?
Now, we were talking about the monounsaturated, how those are the things that you hear are better for you than like the margarine. Like,
Yeah.
I always thought olive oil was better for you than vegetable oil.
Well, there's still fats though. So if you can be in the monosaturated column, that's still better than being in the saturated. Okay. But I know we hear about how olive oil is really good for you, and it is compared to a different type of oil that would be in the saturated, but it's still a fat, okay? And when we're talking about reducing fat in our diet, there are healthy fats, but they're still fats, okay? So if you're trying to lose weight, you're not going to be as successful with even the healthy fats, okay? But again, like you guys said, everything in moderation. Okay, so hopefully we're not using oil a lot to cook our food, even though you don't make everything better. Okay, hopefully instead of using oil at all, you can use like a cooking spray in your pan, for example, or maybe you can get a pan that doesn't stick at all and you don't have to use anything. Okay. Yes, good points. All right, so practice question. The nurse determines that teaching about implementing dietary changes to decrease the risk of coronary artery disease has been effective when the patient says, what do you guys think here?
D.
C. Remember, going back to here, the monosaturated are better, okay? What you want to get out of this picture is you want to try to avoid that first column there, the one that's closest to it that says use sparingly. And you want to move over this way, okay? So those monosaturated fats are found in natural foods, nuts, avocados. So our patients, we should be trying to, for example, I think we talked about this in seminar, if someone really likes to use mayonnaise, okay, mayonnaise is, you don't know it's not good for you, it's not healthy, okay? Even though I love, see, I'm terrible, I'm showing you all my terrible food habits, okay? So if anyone else wants to share their terrible food habits, feel free, so it's not only me. I'm the person that likes to put a little bit of ketchup in my mayo, mix it up, fancy sauce. Have you ever seen Step Brothers? Fancy sauce is a good thing. Dip my fries in it, okay? Yeah. So, for example, a way to substitute out mayonnaise is avocado, okay, a healthier fat, okay? But you shouldn't be thinking, oh, avocado is a healthy fat, I'm gonna eat it 3 times a day, 7 days a week. It's still a fat, okay? Everything in moderation, all right? Okie doke. So how can we, some patients, they can do all these things to try to bring their cholesterol down. Some patients are going to have to go on medications, especially if their reason for high cholesterol is a non-modifiable reason. Maybe it's genetic, okay? So let's talk about some of the lipid-lowering medications. So again, we're always going to try to start treatment by having them change their diet habits, increase their exercise, come back and be reassessed, and if that still is not getting their cholesterol down, then we're going to go to drugs. So the statins, these are the most widely used lipid-lowering drugs. These inhibit cholesterol from being produced in the liver. So, because we're talking about working in the liver, what's the side effect of these statin drugs? Right, we're talking about statin drugs is where we can sometimes have liver problems. So a result of inhibition of cholesterol synthesis is an increase in hepatic LDL receptors. The liver is able to remove more LDLs from the blood. Statins also help produce small increase in HDLs. So statins are mainly for LDLs, but they help a little bit with the HDLs, and they also help lower CRP levels. But side effects, just like you guys said, liver damage, myopathy. What is myopathy? Muscle, right? So when you're talking about myopathy, you're talking about muscle, a muscle condition. When we have a breakdown of skeletal muscle, what does that turn into? Yes, rhabdo. We shorten it for rhabdo, exactly. But rhabdomyolysis is the side effect of myopathy. So what happens to patients that are in rhabdo? Decrease urine output. Why? Why? You're right. Keep going. Yes. So when the muscle gets damaged, when the muscle starts breaking down, when the patient starts going into rhabdo, those are big old honking proteins that are being spilt out, that are being released from the muscle. And those big old proteins clog up kidneys. Remember, the kidneys get rid of waste, okay? So if our muscles are giving off waste because they're damaged from a statin, because maybe, have you ever heard of the old person that laid in their house for a week and they come in and they're in rhabdo and they come in the hospital because they've had all that muscle breakdown from laying on the floor for so long? Those big old fat molecules have to, they're waste, so they go out of our body through our kidneys. Well, they get plugged, they get clogged up, they clog up the kidneys, okay? So these patients, that if they have the myopathy that turns into rhabdo, now they're at risk for kidney failure, okay? And what do we give those patients that are in rhabdo? What do they need? Fluids, flush out those kidneys, okay? So we want to make sure we're monitoring our liver enzymes. We always want to make sure we're rechecking our liver enzymes once they start therapy. How would you know if your patient's developing myopathy?
They complain of muscle aches.
Right, so remember, myomuscle, if they're having a myopathy, if they're having a muscle problem, they're going to start having a lot of skeletal pain, muscle aches, okay? Niacin, or also known as niaspan, is a water-soluble B vitamin, and it's effective in lowering LDL, triglyceride levels. It also increases HDL levels. But again, this med has side effects too. Flushing, pruritus, GI symptoms, orthostatic hypotension. The bile acid sequestrians, these increase the conversion of cholesterol to bile acids, and they decrease hepatic cholesterol, again, to lower total cholesterol and LDLs. Drugs that decrease cholesterol absorption, the Zetia, which is the brand name, the generic name's up here. This inhibits the absorption of dietary and biliary cholesterol across the GI wall. A lot of times, once patients start medications for hyperlipidemia, they're on them for life. We still want to encourage them, though, healthy lifestyle, diet, exercise, along with their medications. Questions about again, these are magic, guys. I know you guys are getting statins in clinical. Everybody good here? So remember, we think statins, we worry about right, myopathy, which could turn into rhabdo, which could turn into kidney failure. Very good, guys. All right, some other medications we can use to treat coronary artery disease: aspirin. Every old person's on aspirin, all right? They all are, okay? This is why. Because coronary artery disease is the #1 killer in the United States of our old people, okay? It still is the #1. This is why everybody's on aspirin, okay? Another antiplatelet therapy, which would be a little more aggressive than aspirin, which would be your clopidogrel or your Plavix. So unless it's contraindicated, low-dose aspirin 81 is recommended for people at risk for coronary artery disease. Who would be contraindicated to taking aspirin? Someone who's bleeding, right, guys? You guys know this, okay? Aspirin thins the blood, so if you're at risk for bleeding, you shouldn't take it, okay? You guys got it. So the current recommendations include low-dose aspirin for men over 45 years and high-risk women, again, unless it's contraindicated. For high-risk women who are intolerant to aspirin, these are patients that can be on Plavix, can be substituted. Healthy women 65 or older, aspirin should be considered if their BP is controlled and the benefit for MI prevention outweighs the risk of GI bleed or hemorrhagic stroke. So again, that's going to be the prescriber's decision to make. What's a greater risk preventing this patient from having an MI versus a GI bleed, okay? Gerontologic considerations in the older adult, again, we said CAD is often a result of complex, non-modifiable, lifelong risk factors. We want to aggressively treat this population with antihypertensive, hyperlipidemia medications. We want to stabilize those plaques that are in their coronary arteries, and we want to tell them to quit smoking. And we want to encourage them to exercise. With their exercise, there's some considerations up here on the board that we would have to modify or change for an older person that we want to start on an exercise regimen compared to if we were talking about a young person. Also, if our older adult is obese, making modest dietary changes and slowly increasing their activity, they're, one, it's a healthier option for them. We don't want to put them out the gate like running. And they're more likely to stick to the plan, all right? Baby steps, right? So we want to assess them. What exercises do they enjoy? Maybe they enjoy riding a stationary bike, but they don't like walking. So those are the things that we should encourage them to be doing. And there's information about heat intolerance in your book too. Remember, our older population, they cannot tolerate the heat as well as the younger population. So again, if we're encouraging them to do exercises outside, for example, in the summer, like walking, you have to take that into consideration for them. All right. Let's take, it's kind of early, do you guys? That's the part that makes me want to vomit. All right, peripheral artery disease of the lower extremities. All right, this is in your book, chapter 37, page 802. Okay, peripheral artery disease is thickening of the artery walls. So what happens as those artery walls get thick? They get narrow, right? They start to close off. So we don't have good arterial perfusion. The risk for peripheral artery disease increases with age. Yeah, yeah, like I said, getting older, everything just goes downhill. I remember when I very first became a nurse, and all the elderly patients would be like, "Don't ever get old, it's terrible," and I'd be like, "Yeah, whatever." Well, now I'm starting to feel it, like, yeah, it does. Little things are starting to change. So PAD increases with age. Diabetic peripheral artery disease can sometimes happen earlier in life. So if your patient's diabetic, they're at higher risk for peripheral artery disease, and it can happen earlier in their lifespan compared to the general population that are more risk when they're older. Prevalence is higher in women and non-Hispanic African Americans. PAD is strongly related to other types of cardiovascular disease, which we just got talking about. Patients with PAD have a higher risk of mortality. They're at higher risk for major coronary events. So, common sites for PAD, this picture is in your book as well on page 803. The atherosclerotic lesions are shown in this picture here in yellow. So the atherosclerosis is going to more commonly affect areas in the coronary circulation, carotid, and lower extremity arteries. Patients start having symptoms of PAD when they have about 60 to 75% blocking of that artery. So again, this takes time, usually years, for this to develop over time. All right, so the risk for PAD increases with age. Patients are usually become symptomatic, and when they reach about the age group of 60 to 80 is when they start having symptoms of PAD. Except for what population? What type of patients will have PAD earlier? Right, diabetics. Very good, guys. The prevalence is equal in men and women, and it's also higher in African Americans. Nicotine, smoking. Nicotine is a vasoconstrictor. Tobacco smoke impairs transport and cellular use of oxygen, and smoking increases blood viscosity and homocysteine levels. That's a big risk factor for PAD. The femoral popliteal area is the most common area for PAD in your diabetic patient. So our symptoms, keep going. Clinical manifestations, what signs and symptoms are patients going to have with PAD? The classic symptom is intermittent claudication, which, what is that? What's claudication? Pain, right. Claudication equals pain. Very good, guys. So intermittent claudication, they have ischemic muscle pain caused by exercise, and it usually resolves within 10 minutes of rest. So we usually have them rest, and then they keep going. They can keep going with their exercise. It is reproducible, and the pain is from a buildup of lactic acid. That's what's causing the pain. So patients with PAD and the iliac arteries, for example, where are they going to start having pain at? Right, the buttocks area, the thigh area. Very good. Patients also have paresthesias from nerve tissue ischemia. True peripheral neuropathy occurs more often in patients with diabetes and in those with long-standing ischemia. Neuropathy will produce a severe shooting or burning pain in the extremity. Patients will have gradual reduced blood flow. They'll have loss of both pressure and deep pain sensations when we're talking about neuropathy. So what's a big thing as a nurse we have to prevent with our patients with neuropathy? Injury, thank you. We have to protect them from injury because they might not notice or have the feeling that they have an injury of the extremity, for example. Pallor, another clinical manifestation of PAD. This is when you blanching of the foot. This happens in response to leg elevation. Or when the foot hangs dependent, it becomes red. That's what we call dependent ruber. Patients often try to get pain relief by either dangling the leg or elevating the leg, sleeping in a chair to allow gravity to maximize blood flow. In your book on page 804, compares peripheral versus peripheral artery versus venous disease, okay? So signs and symptoms are a little different. We're talking now about arteries. We're not talking about like DVTs, guys. This is an arterial problem, okay? So I just like to point that out just to make sure you don't get the two confused. They're not the same thing, okay? Complications of PAD, again, like I said, it progresses slowly. They have prolonged ischemia, so they can have atrophy of the skin, atrophy of muscles, delayed healing to their feet. Ulcers can easily occur because this is an artery problem, and what's that artery carrying? Right, oxygen. Very good, guys. So remember, this is why the patients are going to have delayed healing, why ulcers can easily occur, because they're not getting oxygen to that area, okay? Non-healing ulcers and gangrene are the most serious complications. So what are these patients going to need if they develop gangrene? Right. Unfortunately, these patients are at risk for having amputations. If there's not adequate blood flow or if an infection occurs, then those are the patients that are at risk for amputations. And once something becomes gangrene, gangrene means what? Right, it's dead, it's necrotic, okay? So you can't, no one can walk around with a dead tissue hanging from, on their limb, for example, because what happens is that would be left on there. Right, patients become septic and they die, okay? I have a really gross story about this. It doesn't have anything to do with people, but it has to do with cats. All right, so we live as a country and we had a cat show up to our house. And this cat's leg was missing. It was just kind of hanging there. And so the nurse minded me. And I love animals. And I'm like, oh my gosh, this little cat's got this necrotic leg. This cat's going to become septic to die. My husband's looking at me like, well, anyways, the cat's little leg ended up falling off and had a little stump of a bone, and it was fine. So that cats are, I guess, a little different than humans. He didn't become septic. He didn't die. But I've seen a lot of people, off of the cat subject, I've seen a lot of humans that have ended up with peripheral artery disease, wound infections. And I do have one story about a human. One time when I was working, people always ask me, like, what's the worst thing you've ever seen? I will tell you up there at the top of my list, the worst thing I ever seen was someone that came in and I took his sock off and there were maggots. Just all over his foot, all right? The foot was dead. He didn't, I don't know if it was a psychosocial thing or if he just didn't have healing and didn't know it, but those maggots didn't happen in an hour, okay? That had been going on for a long time. And I can handle a lot of things, but I don't like suction first thing in the morning, and no time of the day do I like a foot covered in that. Okay? And we're only human, guys, and we have senses as well. And we try to be as, compassionate as you can for the patient. We really do. But physically, we were all having to wear masks to go in and take care of him because you just can't yourself physically. It's very, very smelly if you've never taken care of somebody with a gangrenous or necrotic extremity. And usually we're talking about feet here, okay? So don't feel bad if you have to wear a mask, but don't pull the sock off and be like, oh my gosh, what is this? What happened? Totally inappropriate to do that. But it does if you're not ready for it. When you're checking someone in and they're telling you that they're here because their foot's bothering them, and you're like, okay, well, let's get you in bed, and you pull their sock off, and this is what you see. It kind of throws you for a half a second, okay? So, anybody else have any? I'm always sharing my stories. Yes.
We have a guy now in nursing home, and his toes are gangrene, and there's nothing they can do about it. Just wrap on them.
Is he gonna have surgery?
No, they like decided not to, but you can see his veins on the top of his foot starting to go up.
Oh. But, yeah.
We have one in the nursing home, it's been a couple of years now, but yeah, her whole leg up to her knee was injured, the family didn't want to do surgery, so they just kept wrapping it. It was black to the point of like, ugh, it was terrible, and it smells awfully small, in the hallway.
Yeah. And then just imagine the poor patients, because they gotta lay there and see it and smell it as well, and you know that it's gotta hurt, All right, so just always be aware, you never know when you take someone's sock, skin plates are bad enough flying around. I'll take skin plates up my nose any day over a Mac, all right? And when you take off the sock and skin flakes fly, I've seen students do this, guys, don't go. You can't do that either. All right. Where are we at here? So those non-healing ulcers, gangrene, is a serious complication. Amputation may be needed. If PAD happens over an extended period of time, again, collateral circulation might help prevent gangrene of that extremity. Kind of like we talked about collateral circulation in the heart, possibly that could happen in the extremity as well, okay? Uncontrolled pain, severe spreading infections are all indications that an amputation is needed. Geez, I can't talk this morning. All right, diagnostic studies. The Doppler can always determine the degree of blood flow. We can do a Doppler ultrasound to determine the degree of blood flow, especially when we can't palpate one. Maybe we can't get a Doppler peripheral pulse at the bedside. Palpable pulse and a Doppler pulse is not equivalent. Those terms are not used interchangeably. So if you're getting someone's peripheral pulse by Doppler, you need to document it that way, okay? You can't just say, oh yeah, I got their pulse. If you got it by Doppler, that is not equated to palpating a peripheral pulse. You have to document the differences. And then we can also do ABIs, ankle brachial index is also part of a PAD screening tool, and all this is done by ultrasound Doppler. And then angiography, MRIs, these can also help pinpoint location and the extent of PAD. So risk factor modifications, these are the things that we need to hone in on for our patients, to be teaching them. This is stuff that you guys know. In your book on table 37.2, talks about the collaborative care for a patient with PAD. These patients are at high risk for having MIs. These patients are at high risk for having stroke. They're at high risk for CVD death. So with these patients, we want to aggressively treat their lipids. We want to make sure that we're lowering their LDLs, lowering their triglycerides, raising their HDLs. We would like their LDLs less than 100. We would like those HDLs greater than 40. Also, to manage our lipids, dietary changes, and drug therapy used in combination. So again, our statins could possibly be used for these patients. Again, we want to make sure that we're maintaining, controlling their blood pressure. And our PAD patients that also have diabetes or renal insufficiency, we want their blood pressure even lower than 140/90. We want their goal to be less than 130/80. Diabetics are unfortunately a big risk population for having PAD, and they're at even greater risk if they develop PAD for amputation. So we want these patients to have a stable hemoglobin A1C, less than 7 for our diabetic patients, and as close to 6 if we can get them. Some other medications you might see being used for patients with PAD are ACE inhibitors, antiplatelet therapy. Because what's the antiplatelet therapy going to do? How does the action work with these? Right. So remember, go back to that picture that I showed, how we have that lesion sitting in the artery. Well, there's constantly blood flowing through there, and in blood we have platelets, and platelets are very sticky. They like to stick together. So when platelets see that lesion sitting there, it's like a shiny toy, like, oh, what's this over here? And platelets want to stick to it. As platelets are sticking, it just builds and builds where it completely occludes the artery. So what these medications are going to do is keep those platelets nice and slick. So when they're the platelets are going by that lesion, they just go right past it. They won't stick to the lesion. So possibly you might see Plavix and Prilosec. This is a drug alert. Antiplatelet effect of clopidogrel, which is Plavix, is reduced by about half when it's given with omeprazole. So this can increase the patient's risk of having an MI or stroke if that's what we're giving the drug for. So just be aware of that. Warfarin is not recommended for PVD patients. Why is that? This isn't a coag problem, all right? They don't need anticoagulation, all right? That's what Coumadin warfarin is gonna do. Also, it's not recommended that we do any thrombolytics either for these patients. Platol is also recommended as a first-line drug therapy for patients with intermittent claudication who do not respond well to exercise therapy, that are not candidates for surgery or radiology intervention. Exercise therapy, you guys know this. Nutrition, you guys know this here. So what can happen to these patients? Critical limb ischemia. So how do we take care of those patients? So what this is a condition characterized by chronic ischemic resting pain that lasts longer than 2 weeks. These patients get arterial leg ulcers. They can also become gangrenous. We want to make sure that we're protecting that leg from trauma, from injury. We're preventing infection. We're avoiding soaking it. Why is that? Why do we want to avoid soaking the extremity? Right, exactly. It kind of macerates the tissue, gets it too soft. We want to prevent any breakdown, and we want to keep the ulcer clean and dry. Soft protective footwear, avoid extremes in heat and cold. Why is that? Right, they can't feel the extremes in heat and cold, okay? And obviously, protecting those heels from pressure. Spinal cord stimulation might also be helpful in managing pain and preventing amputation in patients with critical limb ischemia. All right.